So we're going to hear today from Dr. Jonathan Waters, who is currently a professor in the Department of Anesthesiology and Bioengineering in the University of Pittsburgh. He's the chief of the Division of Anesthesiology at Magee-Womens Hospital of the University of Pittsburgh Medical Center, and he's also a member of the McGowan Institute for Regenerative Medicine. His areas of expertise primarily focus on transfusion management, blood salvage, and obstetrics. He has been federally funded to support investigation in these areas with over 150 peer-reviewed publications, 5 books on the topic of blood management, and a book on neurologic disease in pregnancy. In addition to conducting research, he has served on the editorial board of the journal Transfusion and is currently serving as an associate editor. He is past president of the Society for the Advancement of Blood Management, and he served on the board directors of AABB between 2011 and 2015. He chaired the Blood Management Technical Advisory Panel for the Joint Commission from 2007 to 2016. He's going to talk to us on the topic blood salvage and bloodless surgery, more nuts and bolts. Thank you, Dr. Waters.
I want to thank everybody for participating in this program. It's something that's been near and dear to my heart for about 30 years now, where I first got involved in bloodless medicine in Cleveland when I was at the Cleveland Clinic, where I met an individual by the name of Sharon Vernon, who kind of introduced me to these concepts. And what I quickly came to recognize is that patients of all colors and creeds did better in their surgical management when they were treated in a bloodless fashion. And we really have expanded from the bloodless terminology to blood management because it's all encompassing. The bloodless component of it is just kind of what I would describe as the goal. But sometimes in patients that are not bloodless, the whole spectrum of care is identical. Now, I think the heart of any bloodless program or any blood management program really should be autotransfusion, or what has been labeled blood salvage. And there's some synonyms for this particular technology: blood salvage, intraoperative blood collection and reinfusion, autotransfusion. It simply means that you're collecting the patient's own blood, doing something with it, and reinfusing it. And so that's what I'm going to talk to you about today. So these are some of my disclosures. I do some consulting work for LivaNova, which is a company that manufactures autotransfusion devices. Likewise with Humanetics, they make an autotransfusion device. And then I also am on the board of trustees for Vitalant, which is the largest independent blood bank in the United States. So to start off with, this is where I'm speaking to you from. This is Pittsburgh. In the foreground of this particular slide is the University of Pittsburgh, with the tall building kind of towards the right side of the slide being the Cathedral Learning, which is the center of the university. I mean, in the background of the slide is the downtown Pittsburgh, and you see the tallest building there is UPMC headquarters. That's the University of Pittsburgh Medical Center. We're the largest employer in the state of Pennsylvania with about 180,000 employees providing health care. And 43 hospitals in the United States, and then 18 hospitals in overseas locations. So this is to orient you to the geography. This is where Pittsburgh is located. And this is the city itself. And I'll outline the importance of this in a moment. But Pittsburgh is formed in the middle of two rivers, the Allegheny River and the Monongahela River, which forms the Ohio River, which in turn flows into the Mississippi River. The city of Pittsburgh sits in the confluence of these two rivers. And so I wanted to talk a little bit about the history of allogenic transfusion, and then migrate into autologous transfusion. Allogenic means that it's blood being transfused from somebody else. Can either be a person or an animal. And then autologous transfusion is transfusion of blood from the individual. So this all started with William Harvey back in 1628, where he discovered circulation. And we might think of this being very intuitive, but at the time, people thought that the blood was circulated in two different circulations, one being the right side of the heart and the other circulation being the left side of the heart. There was no understanding that there was a connection between the two. And the right side of the heart carried blood that was blue, and the left side of the heart carried blood that was red. Neither should meet, at least that was the understanding in 1628. And William Harvey was brilliant by doing some experiments where he demonstrated that the blood was all flowing in one direction through the valves of the venous circulation. So around the same time, this concept of blood transfusion was launched. And this is a woodcut showing the first transfusion that took place in an individual who had what sounds like schizophrenia, or could be neurosyphilis, where he was transfused with blood from a goat, or a sheep rather, thinking that the sheep blood would make him more docile. And so there is some mythology around this particular transfusion, in that this individual ultimately succumbed to his anemia, or his wife's cyanide. But at any rate, there is some information in the literature that says that the Pope in Rome banned transfusion practice at this point. There is some controversy as to whether that truly happened, though there was also the French Society of Medicine decided that this wasn't a very good treatment either. So this really kind of stopped transfusion, at least for the next 150 years, until James Blundell in 1818 published a report as he observed a woman die during childbirth. And this unfortunately happens about 500,000 times around the world, where somebody dies during childbirth. And this was James Blundell's solution, was to basically transfuse human blood. And in this era, it was typically blood from the father, as is demonstrated here, where the blood was transfused from the dad into the hemorrhaging mother, and hopefully was life-saving. And then in 1819, Blundell published a case series of 10 reports where this is the way that it was done through this Blundell blood gravitator. But this particular technology didn't really catch on, and for a couple reasons. One is that the results were somewhat haphazard, because there was no understanding of blood typing. So, if you're transfusing somebody with a blood A type to somebody that has a blood B type, it's going to be a fatal transfusion. So there's no benefit. There was also no ability to anticoagulate the blood. And so the blood had to be transfused direct from the donor to the recipient. And so these obstacles really prevented widespread use of transfusion medicine. It wasn't until this gentleman in 1918, during the First World War, really advocated for the use of citrate to basically anticoagulate the blood and then transfuse it. And this is kind of the initiation of the modern day blood bank, was through this individual, Albert Houston. So getting back to the map of Pittsburgh, this star here represents where bloodless medicine started. This was where the Jehovah's Witness church was founded, and this is a plaque memorializing the location of the original Bible Tract Society on the north side of Pittsburgh. So in this region, we take care of a very large number of these patients that require bloodless interventions, and it sums about 1,600 patients per year that come into our hospitals. So we have to be respectful of their wishes, like any other patient. And so we've developed, I think, pretty much the premier bloodless program in the United States, and it's because we have such a large patient population of these patients. And so I'm going to get a little controversial here. These are some of the scriptures that identify why the Jehovah's Witnesses prefer a bloodless healthcare. And it basically is that blood should not be consumed. And it's interesting that if you look at what will be accepted by bloodless medicine patients, and this is a position paper that comes from the Watchtower, which identifies what is acceptable and what is refused by this patient population. It's interesting that the major components of blood are refused, but there's some fractions that are left to the personal decision-making of the individual, and this is where it gets kind of cloudy. And I think this is what is confusing for many healthcare providers, is the refused products and then the potentially acceptable products. So, as a healthcare provider who is not a Jehovah's Witness, I find this particular page on the website of the Jehovah's Witnesses to be particularly useful. There's some information here for clinicians in what is acceptable and what is not. And I would encourage any physician that's caring for these patients to seek out this information. And this highlights from the Watchtower, the need for personal decision-making being incorporated into the care of these patients. And I think this is really important, and we've kind of leveraged this concept for our use as it relates to autotransfusion. Autotransfusion is, again, the collection of spilt blood and the processing of that blood and then the reinfusion. And some Jehovah's Witnesses will accept this processing and some will not. And usually what we do when we get patients that are against the autotransfusion, we'll generally bring in church elders to speak with the patients and determine whether they truly understand that it's their own blood that's being used. And in the vast majority of circumstances, this will get acceptance. Now, as I was putting this lecture together, this particular statement jumped out on a Google search that I did, where these are some statements made by the Roman Catholic Church that the act of donation of blood is an expression of human solidarity and of Christian charity. And I thought that this was in somewhat contrast to the teachings of the Jehovah's Witness Church, and which leads me to some comments about what's going on here in the United States, where there are certain states, Texas, Jessica, you may be aware of this. Texas is in the process of mandating that patients have access to their own blood for transfusion. The state of Montana has also passed forward legislation that defines that a patient should have access to blood from patients that have not been vaccinated. So we've thrown in this huge, not only religious schizophrenia, but we've also thrown in politics into the transfusion of blood. And I think that the way we get around all of these individual perspectives is through the use of autotransfusion, where the patient gets their own blood. They're not exposed to a patient that's been vaccinated or somebody that is walking around with blood that they don't want. So that leads me to the history of autotransfusion, or the transfusion of a patient's own blood, which started with this publication in The Lancet by William Highmore, who is a physician, once again in England, who, in the observation of a mother bleeding to death in bed following delivery, and he thought, wouldn't it be great if we could collect that blood, defibrinate it, warm it, and then inject it right back into her. And if you look at the bottom of this particular statement, this is what it says. And this is kind of the first report that I'm aware of autotransfusion, though there's some reports earlier of autotransfusion, but this is the first really published account of doing so that I'm aware of. So this was the primary way of transfusing patients for about 50 years until Albert Houston discovered citrate anticoagulates blood. But there's a number of case reports in the literature of autotransfusion being performed. And this is one of the reports from this journal, California and Western Medicine, where they reviewed 272 cases. And these cases were mostly ectopic pregnancies where the blood was collected and reinfused. And this particular idea evolved into the Bentley autotransfusion system, which is shown here, where the sphere on the top of the device was used to collect blood. It was suctioned out of a bleeding patient, this is shown on the right side, and stored in this reservoir, filtered, and then pumped right back into the patient. Now, this device didn't have a long lifespan because the roller pump on this device wouldn't stop when the reservoir would empty. And so there was a number of case reports of air emboli occurring from the use of the Bentley autotransfusion system. So it was taken off the market pretty rapidly, but it was an extension of this whole concept of autotransfusion. So now we've evolved into having these more sophisticated devices. This is a picture of a device that I used at the Cleveland Clinic. It was a Medtronic Sequestra. And just showing you the pieces and parts of the device with a primary reinfusion bag where all the action is occurring. Now, the reason I think autotransfusion should be at the center of any bloodless program is illustrated by some mathematical modeling that I published probably around the year 2000. And this is a mathematical model of a patient bleeding. And this dotted line is representative of the bleeding, and the x-axis on the bottom represents the amount of blood loss, and the y-axis on the left of the slide represents the patient's hematocrit. So if we started with an idealized patient with a hematocrit of 45% and a body weight of 70 kilos, this patient would be able to tolerate about 3 liters of blood loss with no intervention other than just volume support through crystalloids or colloids. Now, if you add autotransfusion onto it, the curve looks a little differently, where it looks like this sawtooth, where if you take the same starting point of a hematocrit of 45% and you bleed, at some point you've collected enough blood that you can transfuse that blood back to the patient. So that's what leads to that sawtooth, where you retransfuse the blood that's been lost. So there's a bump up in the hematocrit. And so as the patient bleeds during the course of their care, you have a technology that is able to take somebody that would only tolerate about 3 liters, you take them out to being able to tolerate about 8 liters of blood loss through this technology. And there really is nothing else in our medical armamentarium that allows for patients to tolerate this kind of expansion of their blood loss. And so just to compare, no techniques being applied on the top and the autotransfusion on the bottom. And so you can see we can take somebody that's starting at a normal point and just expand double and sometimes triple. And my own personal record for this particular technology is transfusing 271 units of blood from an autotransfusion device in somebody that had a ruptured thoracoabdominal aneurysm. So it's really pretty astounding what it's capable of doing. And so this is kind of the heart of our blood management program. And this is what I describe as our 6 steps of our blood management program, with autotransfusion being item number 3 here, highlighted in red, being the key. And I think this is really, I think, the heart. You can talk about anemia management all day, but it's not going to allow you to tolerate 10-liter blood loss. So we have a number of devices that are available to do this. And there is also some devices that have been introduced. The device on the right is the HemoClear, which is basically a filter. The device on the left is the basically a giant syringe that sucks blood out of a patient. You flick a stopcock and then you pump the blood back into the patient. The device manufactured by Sisu allows for use in the third world, where you can't use a device that requires electricity and all of the drugs that go along with providing that product. So intraoperative autotransfusion can be used in a lot of different environments, as illustrated here. And I guess my time is growing short. But this was a paper that was published, or a report of the care of a patient, a Jehovah's Witness, who refused autotransfusion. And these investigators advocated doing it with a continuous circuit. And I've talked with the Watchtower on a number of occasions, and they don't really understand how this idea came across where, the continuous circuit was necessary. And I think that it was a marketing scheme. These devices process in batches, whereas this device, the one on the left, the continuous autotransfusion system continuously processes, so you can continuously provide blood that's washed with this device. And I think it was a marketing ploy from the company that manufactures this device to get Jehovah's Witnesses to advocate for this continuous circuit. And I don't really think this is necessary, and the Watchtower seems to agree with me. But if you want to do this, this is how you would strategize your reinfusion, is through here. And I'm just going to flip through the instructions on how you would go about doing that. I guess Nathaniel is going to post my slides so you can read through that recipe of how you might do it if you want to do a continuous circuit. One of the things that's necessary to make autotransfusion efficacious is rinsing of your sponges, as is shown here. And you can remove about 95% of your cells through the rinsing of sponges. Once again, this is the patient's own blood that you can return to them. So just to finish off, I want to just highlight some of the differences between autotransfusion red cells or autologous cells and blood that comes from the blood bank. This is some work that was done with radio labeling of red cells, those that were washed and those that were unwashed, and the lifespan of those cells was basically identical for this particular study, or in this particular study. And the shapes of the red cells maintains its normal integrity, as is demonstrated on the left, where they take on an echinocyte shape when they're stored for a couple weeks, as is shown on the right. And then there's been some work done looking at contamination of stored blood. This is some of it, fibrin degradation products, which is breakdown products from clot, where if you look at washed blood, it provides something that's equivalent to what's circulating in the patient. Plasminogen activator and activator inhibitor are also washed out. Complement, likewise. Elastase, which is an enzyme that comes from white cells, is also washed out to a level of what's circulating in the patient, and serotonin also. So I equate blood from autotransfusion to this steak. The steak on the right has been refrigerated 21 days, which is the same length of time that blood is stored. The steak on the left is straight from the butcher. And this is the difference between a blood bank unit that's been stored and cell salvage blood. The blood bank unit that's been stored has that kind of brownish color, whereas the autotransfusion blood looks fresh and healthy and whole. And if I was eating that steak, I'd rather have the one on the left that looked fresh. And likewise, if I'm getting transfused, I'd prefer to have blood that looks red and healthy and pink. So again, this is our strategy, and I will defer to the Australians who came up with pillars instead of steps for what they advocate for their autotransfusion program. And I think I will end there, having expended my 30 minutes, and just leave it for any questions.